disclosures. In general, the treatment of iliac occlusive disease has a somewhat established algorithm in that we have data to support the use of covered balloon expandable stents for osteal disease, severe calcification, and task CD lesions. Many operators use balloon expandable non-covered stents if the internal iliac artery needs to be covered. Self-expanding stents have historically been used, especially in the external iliac artery and especially distally. And then there is, of course, a role for self-expanding covered stents if there's presence of thrombus, especially in the external iliac artery. However, as we increasingly treat complex disease with endovascular techniques, what do we do about treating lesions that involve the aorta or with very extensive task C or D lesions? Previously, few devices have been designed specifically for this purpose, and this has been partly due to some limited size matrices as well as few data available for complex disease. However, in the next few minutes, I'll discuss the role of some of the newer covered balloon expandable stents as well as aortic endografts that I think have greatly increased the options for endovascular treatment of complex disease. To begin with a case, this is an example of a 74-year-old man who had severe right lower extremity claudication and moderate left lower extremity claudication. CTA demonstrated a right common iliac occlusion and high-grade stenosis of the left common iliac artery. You can see here at this baseline angiogram that the patient has a moderate caliber aorta and occluded right common iliac artery at the ostium with disease of the left common iliac. In this case, we're able to cross the lesion retrograde with a straight stiff glide wire. We utilized intravascular ultrasound to confirm an intravascular location of the reentry site and pre-dilated with a 5mm balloon. Subsequently, this case was treated with simultaneous deployment of bilateral balloon expandable covered stents that were initially placed at 7mm stents, but then were post-dilated up to 10mm on each side. And then this is the final angiographic result. So you can see that this case, while it does involve the distal aorta, was primarily at the bifurcation and the origin of the common iliac artery, and I think we've all treated these types of cases with excellent results. But increasingly, there are newer covered balloon expandable stents that I think have some advantages in this space. One of them is the Viabond VBX. This has a predictable deployment with stability on the balloon, unlike previous balloon expandable covered stents, and I think the ability to really land directly at the ostium. There's also, importantly, a wide range of post-dilation sizes. The 8L stent is particularly helpful as it can be dilated up to 16mm, providing some utility in aortic interventions. And I think there's also very high flexibility of newer generation balloon expandable covered stents that actually have excellent performance in the external iliac arteries as well and change some of the concept of using where to use self-expanding versus balloon expandable stents. Importantly, the VBX Flex study has had 2-year results presented which actually demonstrated a freedom from TLR that was outstanding and actually similar for both task AB and CD lesions with rates approaching a 95% freedom from reintervention. So what about other techniques to use when aortic disease is concomitant with iliac disease? Well, one of them is the Cwrap technique, which has been popularized in Europe. This stands for the covered endovascular reconstruction of the aortic bifurcation. This has some potential flow dynamic advantages compared to standard kissing stents. In this example here, you can see that kissing stents, when they're deployed, tend to result in a radial mismatch in the aorta, whereas when a Cwrap technique is used, where a single large stent is placed in the aorta and then 2 stents inside that stent, you get better flow dynamics and less radial mismatch, potentially resulting in better long-term patency. This is an example of a patient with severe bilateral lower extremity claudication and severe ischemic rest pain. You can see he had a heavily diseased distal aorta, occluded left common iliac, and disease of the right external iliac as well. We were able to cross this lesion from a brachial approach with a straight stiff glide wire that was knuckled, externalized, and then placed an 8L balloon expandable covered stent in the aorta, dilated that up to 16mm, and then placed kissing covered balloon expandable stents in the ostia of the common iliac arteries with this final result and resolution of the patient's claudication and rest pain. And the 3-year outcomes of the Cwrap technique have recently been published, which demonstrated patency rates that were outstanding and freedom from reintervention in the range of 90%. suggesting that this is a viable technique for patients who have concomitant aortic and iliac disease. However, things can get more complicated with sizing of the aorta and also if there's concomitant aortic aneurysm. This is a 64-year-old man with Rutherford 3 claudication, with bilateral thigh and calf claudication, with an absolute distance of walking of 100 feet. He was unable to complete a walking program. And a baseline ABIs were 0.54 and 0.51, and you can see his baseline CTA demonstrated that he had an infrarenal aortic occlusion with reconstitution in the bilateral external iliac arteries. In this case, we're able to navigate through the area of the occlusion utilizing orthogonal imaging and an Astato 30 wire to re-enter into the aorta. And this resulted in true lumen crossing from the right side and then from the left side. And then once the wires were in place in the aorta distally, the question becomes how to size this appropriately. This patient's aorta was more in the range of 26 millimeters, and with it not being undersized, this makes it difficult to use a simple balloon expandable stent. Our approach, therefore, was on the right side to place covered balloon expandable stents throughout the common and external iliac artery here, which you can see extending from the ostium of the common iliac down to the distal external iliac. This essentially creates an endoconduit, which made it possible to then advance through that area a 17 French sheath with a plan of reconstructing the bifurcation with an AFX to endograft device. While this device was designed for aneurysmal disease, we do have data to support its use in aortic occlusive disease as well. This just demonstrates that graft being advanced and the wire snared from a contralateral approach. And then we're able to deploy the unibody device, the bifurcated device, through the aorta and the distal common iliac arteries and reconstruct the aortic bifurcation with further post-dilatation, resulting in final angiographic appearance with excellent flow to the bilateral iliac arteries and reconstitution of his flow. This just demonstrates the preoperative as opposed to postoperative angiograms. This patient remains free of claudication. We actually have some multicenter data to support this approach, published by Maldonado et al. In 2016. This included 91 patients with symptomatic aortoiliac occlusive disease. And at 2 years, there was an 88% freedom from secondary intervention. I think suggesting that these advanced aortoiliac techniques have really demonstrated the ability to treat essentially all of these lesions with endovascular techniques, utilizing some of these newer devices with high rates of procedural success and low morbidity. I think importantly, procedural planning is crucial for sizing in order to decide on the exact type of graft and stent to use for these cases. Thank you very much.